Ladies and gentlemen, Professor Crawford.
Well, it's my pleasure to present the results of this study, which was conceived approximately 3 years ago and has been undertaken with great enthusiasm by a number of investigators that we will credit towards the end of the presentation. I just want to thank you for that flattering introduction. And I look forward to you enjoying the next few minutes as we present the results of these findings. So we all know that there is a high incidence of PTSD in Australian ex-servicemen, with almost 5% of military veterans reporting to having symptoms and 16.5% in ex-serving regular members. Poorer health has been observed in Vietnam veterans with PTSD, and there's an increasing body of literature which suggests that individuals with PTSD have worse long-term health outcomes. So with that brief background, we undertook a study to improve the understanding of illnesses, physical illnesses if you like, and physical symptoms that were potentially associated with PTSD, and to identify the conditions. And we will be undertaking further investigations to look at potential pathophysiological and genetic mechanisms of these conditions. So our participants were able to be included in this study if they were Australian males who served as members of the ADF in Vietnam during the Vietnam War. Subjects were excluded from the study if they had an underlying diagnosis of schizophrenia or a bipolar disorder, or they were unable to attend all required appointments. Recruitment was largely through referral through Greenslopes Private Hospital, supported by advertising in a number of sites, including GMRF and RSL websites, RSL publications, posters and flyers, newspaper advertisements, and word of mouth. The subjects underwent a very intensive evaluation, which included issues related to their participants' history, clinical evaluations, which you can see are a number of different, quite advanced, some of them medical evaluations, psychological evaluations, and sleep study. So these subjects, we are so grateful for their participation in this study, as you can see, dedicated a substantial amount of time to support this study and make the data as robust as what we could possibly hope. The participants were grouped according to the diagnosis of PTSD. In other words, throughout the results of this study, you'll see that the subjects are presented with and without PTSD, the two groups of cohorts. And this was based upon a psychiatric diagnosis of current and or past PTSD and a clinician-administered PTSD scale called CAPS, the diagnosis of current or past PTSD as determined by a clinical psychologist. There are just the next couple of slides relate to some of the statistical methods associated with the study. As you can see that the different variables that we investigated could have three different forms. They could be a binary form, in other words, a yes, no. They could be a categorical form, which for instance might be a body mass index category, or they could be a continuous variable such as weight, and the relevant statistical methods associated with the analysis of data of this type is on the right-hand side of this figure. Obviously, those amongst us who understand, or those amongst you who understand statistics, multiple tests were applied to this data, and there is a false discovery rate method which was applied to strengthen the statistical value of some of the findings. So the results of the study were that when we looked at participant recruitment, 554 veterans were screened, 311 provided consent and met inclusion criteria. We were able to undertake psychiatric evaluation in 296, with 137 diagnosed as no PTSD and 159 diagnosed with PTSD. And you'll recall that the other inclusion criteria was that the diagnosis be confirmed by a clinician-administered PTSD scale from DSM-5, and so 105 subjects were confirmed as having PTSD and 108 confirmed 105 were diagnosed as no PTSD and 108 were confirmed as having PTSD. So this slide shows you the demographic features of these two cohorts. Because they were Vietnam veterans, the age was almost 70 years in both groups with no significant difference. Those subjects with PTSD had a trend towards a higher weight and tended to have more subjects in the obese category as defined by a BMI of greater than 30. There was no difference in terms of current smokers, but patients with PTSD were more likely to have smoked within the past 12 months. The smoking pack year history was higher in patients with PTSD than patients without PTSD. The response to the question about current consumption of alcohol was higher in patients without PTSD than what it was in subjects with PTSD, and there is really no differences in the ethnic background of the populations. Further demographic data showed significant differences in employment status, with subjects with PTSD being much less likely to be not working than subjects without PTSD. And there were differences in the highest education level, with subjects with PTSD, with more subjects with PTSD achieving year 10 or less than year 10 than those subjects without PTSD, and more subjects without PTSD going on to university or year 11 and 12 at school. The physical outcomes are summarised really in this slide, where the differences between the groups were really categorised in the following areas of interest, with the largest and most significant differences existing in relationship to sleep behaviour, symptoms associated with gastrointestinal disease, ultrasound findings and history of alcohol use, cardiovascular symptoms, respiratory symptoms, systemic markers of inflammation, and then other findings of which there was no significant differences between the groups. So we'll go through some of these areas of interest in some depth. And firstly, we turn to sleep disorders, and subjects with PTSD had a much higher risk of REM behaviour disorders, almost a fourfold risk, a twofold increased diagnosis of sleep apnea, almost a twofold increased risk of restless legs, and a higher likelihood of what we call sleep disordered breathing, which is really associated with or due to increased daytime fatigue. I won't go into these subsequent slides in detail, but you can see, for instance, that the subjects with PTSD, that almost 77% of subjects had REM behaviour disorder sleep, compared to only 20% in the subjects without PTSD. In PTSD patients, there was nominally higher sleepiness as measured by a well-recognised Epworth sleepiness scale. When we move on to the gastrointestinal system, PTSD participants had a higher risk of stomach ulcers, reflux symptoms, and higher risk of constipation and a diagnosis of irritable bowel syndrome, and a trend towards increasing risk for other problems. For example, diarrheal symptoms were almost 3 times more common in the subjects with PTSD than those subjects without. And this is illustrated, the strength of these associations is illustrated in this slide, where you see almost 70% of subjects with PTSD complaining of reflux, over a quarter having a history of stomach ulcers, again almost a quarter with irritable bowel syndrome, and a lot higher proportion of patients with constipation than the subjects without PTSD. Liver and alcohol use is interesting. In the PTSD patients, on ultrasound examination, they had a much higher risk of abnormal liver texture. This may be related, I think, to fatty liver disease, possibly associated with alcohol consumption and a slightly higher BMI in the patients with PTSD. The current consumption of alcohol was lower in PTSD, participants, but alcohol dependence and problem scores associated with the audit screen were much higher, and we think that this really does reflect significant past alcohol use. And again, that you see that in subjects with PTSD, about a third of those subjects had abnormal liver texture on ultrasound versus only about 15% or 14% in subjects without PTSD. And again, this slide illustrates the alcohol dependence and the alcohol problem scores being much higher in subjects with PTSD than subjects without PTSD. In relationship to the cardiovascular system, PTSD participants had almost a fourfold higher risk of a history of myocardial infarction, and for a reason that we really can't explain, about a fivefold higher risk of heart valve problems. They also tended to have higher triglycerides and lower HDL levels, suggesting they may be at higher risk of developing atherosclerosis and cardiac events related to that. And again, this is illustrated in this busy slide, which shows that the frequency of heart attacks and myocardial infarction was almost 15% in the patients with PTSD, compared to about 3.8% in subjects without PTSD. Well, in regards to the respiratory system, patients with PTSD had a higher risk of wheeze and shortness of breath, and also in general have about a 5% lower respiratory function compared to those without PTSD. We need to go back and examine this data and adjust for confounders such as cigarette smoking, and to see whether that itself explains this difference, or whether there are other as yet unidentified factors that may explain this slightly impaired respiratory function in the patients with PTSD. We've also looked at some inflammatory markers, or some biochemical markers which can be associated and increased in systemic inflammation, and both alpha-1 antitrypsin and serum ceruloplasmin levels were slightly higher in the patients with PTSD. So to summarise, the patients with PTSD tend to have a cluster of symptoms associated with sleep, respiratory function, altered liver texture, gastrointestinal symptoms, a higher rate of cardiac disease, and particularly myocardial infarction, and problems with alcohol use over time. Our future work in the field, really, we need to go on and do additional analyses to evaluate the effects of confounders, determine which of the results are directly attributable to PTSD alone. For example, as I've given the example of smoking, respiratory, and its effect on respiratory function and wheeze, and the effect of cholesterol-lowering drugs. So we will move on that additional analyses quite quickly. Many of you know that we have a biobank associated with this study where we've stored DNA and serum. And so we'll be looking at genetic associations for PTSD. We'll be examining additional inflammatory markers such as serum levels of various interleukins, TNF-alpha, and some of the neuropeptides. And we are going to undertake a neuroimaging study where we look at regional brain volumes and tractography. The biobank has samples from 295 participants for the development of this PTSD biobank, with blood and saliva and semen from 40 participants. And the aim is to really foster collaborations and with world-class PTSD researchers both within this country and throughout the world. So, as Air Chief Marshal Mark Binskin said, more effective mental health policy and programs can be developed to better meet the needs of serving members and contemporary veterans. And we think the results of the current study will inform the development of a study and how it should be undertaken and what should be examined in contemporary veterans. So I said at the start of this presentation that there are a number of institutions and a number of investigators who have enthusiastically participated in this study to have this number of doctors across this number of institutions as enthusiastic and cooperative in the conduct of a study is a feat in itself, I can tell you. But it's been wonderfully managed by the staff of the GMRF, and I notice Miriam is not on this slide, but she has clearly driven a lot of this work. The psychiatrists, Bruce Lawford, Professor Ross Young from QUT, who's Graham Cooksley, who's a liver specialist, David Colquhoun, who's a cardiologist who made substantial contributions to the design and conduct of this study, Chris Strakosch, who's an endocrinologist and extremely interested in some of the endocrine evaluations, John Gibson, a psychiatrist who has gave an enormous amount of time for the conduct of this study, Robin O'Sullivan, who ushered in the idea to us that we should really start to investigate sleep patterns in these patients, because she had noticed in a clinical practice that the prevalence of what she thought was a high prevalence of sleep disorders in subjects with PTSD, and the paucity of literature around this issue. And Rachel Thompson, her collaborator, who's also a respiratory physician, Philip Morris and Joanne Vossi who are both geneticists, and we're really looking forward to some of the genetics work that comes out of this. Wendy Harvey, who's a medical officer at Greenslopes, who again did a lot of the assessments and a lot of the day-to-day operational work associated with the conduct of, I'm sure those of you involved in clinical investigation will know the extent and the amount of work that's involved in this number of evaluations in 200, nearly 300 subjects. Madeline Romanek, who's a psychologist associated with the study, again, tireless devotion to the work, and Sarah McClay, who has done all of the statistical analysis and made the results so presentable and so easy for us to understand. So this is some more information on GMRF Foundation, but I think I will stop there and acknowledge all of the institutions that have helped with the study, the RSL in particular, Greenslopes Private Hospital, Sullivan Nicolaides, CSIRO, Queensland X-Ray, QUT and the University of Queensland. Thanks very much.